Hi friends, welcome to this FMGE January 2024 examination recall pediatric questions. We will be discussing the pediatric questions that were asked in this year FMGE January 2024 exam. Before I start again, the standard disclaimer which you should be aware of. All faculties come up with this, and you, I'm sure, are intelligent enough to understand that the answer to these questions actually is based upon the options that I've been able to get from the students. So in case the options are different from the options that were actually asked in the exam, now we have tried to keep the questions and the options of these questions as much as to the actual question as possible. However, in case the questions were different or the options were different, then the answer to the whole question can change. With that disclaimer in mind, let us start with these questions. So the first question was a question which was about a 2-day-old male neonate who was wheeled into the emergency by the mother, and the child picture was given, and you can clearly see an outpouching which is seen from the umbilicus. They say the signs and symptoms of the child were fever, abdominal protrusion, and swelling in the umbilicus with a membrane covering. Now this is very important, with a membrane covering the gastric components. So if you actually see, you have a pouch which can be seen coming out of the umbilicus, and this pouch contains the bowel, and surrounding it is a membrane which is most likely the peritoneum. So what is this condition most likely? So this is basically an abdominal wall defect. Now there are many abdominal wall defects, but two of the most common abdominal wall defects that you see in children are omphalocele and gastroschisis. Now what is the difference between an omphalocele and gastroschisis? Now both of them are abdominal wall defects, congenital abdominal wall defects in children. But what is the difference between them? See, omphalocele usually is central in location. So it is an abdominal wall defect which is basically umbilical in location. So the contents that will be outpouching will be from the umbilical ring. In contrast, the gastroschisis, the outpouching will be usually para-umbilical. So it will never be from the umbilical ring. It will usually be from the right of the umbilical ring. So here you can very clearly see that the protrusion is from the center of the abdomen, that is from the umbilical ring. So this is unlikely to be a gastroschisis because gastroschisis are usually para-umbilical. That is from the side of the umbilicus. The second thing that you need to know is that why is this an omphalocele? An omphalocele is basically a protrusion from the umbilical ring which is covered by an peritoneum. So you have a small outpouching as you can see here, and this outpouching may contain the bowel, and this is surrounded by a intact peritoneum. In fact, in the intrauterine life, there will be a covering to the sac, and that covering, the inner layer might be the peritoneum, the middle layer might be the Wharton's jelly, and the outer layer might be the amnion. However, gastroschisis is basically a protrusion which is seen from the abdominal wall, and it is not covered by any peritoneum. So there is no covering at all. So you will actually see the gastric contents out of the periumbilical abdominal wall defect, and there won't be any covering to those bowel wall contents. Here you can very clearly see a covering that is present. So this again goes in favor of an omphalocele. Umbilical hernias are very different. Umbilical hernias usually are when the umbilicus falls. A small hernia can appear from the umbilicus. That is usually seen in newborns, and it is a very common condition. And most umbilical hernias which are seen in children in the first 6 months of age usually correct on their own. So you don't need to do surgeries in large majority of umbilical hernias because most of them get correct on their own by about 1 year of age. Ectopia cordis is basically more of a thoracoabdominal wall defect where you can see actually the outpouching, which is the heart. So here actually in the picture you cannot see any such type of a thing. So this is most like an omphalocele where you are seeing the gastric contents which are, or the bowel contents which can be seen in a pouch arising from the umbilicus and covered by an intact peritoneum. Omphaloceles usually are many times associated with many other congenital defects, and therefore they are usually part of syndromes. Gastroschisis are usually solitary congenital defects, but omphaloceles are usually part of many syndromes. because they are often co-associated with some other congenital defects. So all in all, this is most likely an omphalocele, which can be seen in the picture. Coming to question number 2, something which we have discussed many times in our classes also. This is a neural tube defect, anencephaly, and they are asking anencephaly occurs due to inability of the neural tube to close by which week of antenatal life. Now we have very clearly discussed this in our classes that the neural tube, which is basically the precursor to the brain and the spinal cord, it usually closes by about 3rd to 4th week of intrauterine life. So anything which interferes in the closure of the neural tube between the 3rd to 4th week of intrauterine life will result in either the cranial part of the neural tube or the spinal part of the neural tube, or in some cases both the cranial and the spinal part of the neural tube, which may remain exposed to the environment. So this is a neural tube defect. And anencephaly is basically a type of a cranial neural tube defect, because here you have the brain which is totally exposed to the environment. So it is basically because of failure of the neural tube to close between the 3rd to 4th week of intrauterine life. Now, according to students, both 3rd week and 4th week of intrauterine life were mentioned in the options. So I obviously will go by the 4th week, because the time by which we expect the neural tube to close is 3rd to 4th week. So even till the 4th week of intrauterine life, we expect the neural tube to close. So this is a type of a neural tube defect, which is cranial type of a neural tube defect. Another type of a cranial neural tube defect, which is closed in type. This is an open cranial neural tube defect. Another type of a closed cranial neural tube defect is basically when a part of the brain can be seen herniating out. The whole brain is not exposed to the environment. A part of the brain can be seen herniating out. Usually it's the occipital part of the brain, the back part of the brain, which can be seen herniating out. That is called as an encephalocele. Anencephaly is more of a open type of a cranial neural tube defect, because here the brain is totally exposed to the environment. And there are various factors which can lead to neural tube defects. And these factors can include folic acid deficiency in the mother, or mother taking 1st generation anti-epileptic drugs, or many times diabetic mothers. Children who are born to diabetic mothers have a very, very high risk of having neural tube defects. So these are the factors which can interfere in the closure of the neural tube and therefore lead to the development of neural tube defects. And the prevention of neural tube defects usually is by periconceptual use of folic acid by the mother. So the dose is 0.4 milligrams per day of folic acid when we are attempting a primary prevention of neural tube defect, and the dose is usually 4 milligrams per day. Although again this is debatable, but theoretically yes, 4 milligrams per day for secondary prevention of neural tube defect. So question number 2, the answer is the 4th week of intrauterine life. Next question is stranger anxiety. Now this is a milestone. Stranger anxiety basically is when the child develops anxiety to strangers. It is a type of a social milestone that usually is seen in children, and usually is seen to appear at about 7 months according to me. So 7 months of the life, which is the part of infancy, is the time when stranger anxiety usually is known to develop. Don't confuse stranger anxiety with separation anxiety. They both are different terms. Stranger anxiety is when the child develops anxiety to strangers. And most children are known to show stranger anxiety usually by 7 months of age. But since 7 months of age was not, according to students, the options, so according to me, 6 months should be the best answer for stranger anxiety in children. So this is a type of a milestone that develops in children. Then there was a question. In fact, there were some questions on vitamin deficiencies which came in this exam. So I've done vitamin deficiency. If you have done vitamin deficiencies and vitamin manifestations of vitamin deficiencies, then you are likely to have done well in this exam, because there were, I think, 3-4 questions which were asked on vitamin deficiencies. Now, one of the questions according to the students was a question where they asked angular cheilitis, stomatitis, glossitis are usually manifestations of which vitamin deficiency. Again, although per se this is not a pediatric question as such because it was not mentioned in children, but vitamin B deficiencies are actually associated with a myriad of symptoms, and the symptoms and manifestations may depend upon which vitamin deficiency we are talking about. For example, when we talk about vitamin B1 deficiency, that is thiamine deficiency. So thiamine deficiency in children has been associated with a condition which is called as beriberi. Now, beriberi may be a dry beriberi, which includes polyneuropathies, motor and sensory symptoms that may develop in the child. Wet beriberi is where cardiovascular manifestations, edema, heart failure may develop in the child. And then vitamin B1 deficiency may also be associated, especially in adults, with a condition which is called as Wernicke's encephalopathy. So here, ocular manifestations, gait abnormalities, confusion, these may be present. Now, vitamin B2 deficiency, which is actually riboflavin deficiency, is actually associated with classical manifestations of chillosis, lip swelling, angular stomatitis, that is cracks at the angle of the mouth, glossitis. It is also associated with seborrheic dermatitis like manifestations, photosensitive manifestations on the skin. But angular cheilitis, stomatitis, glossitis, according to me, are classical manifestations of riboflavin deficiency. Vitamin B3 deficiency or thiamine deficiency is often associated with niacin deficiency is often associated with a condition which is called as pellagra. So the classical 4Ds, diarrhea, dermatitis, dementia, and death, are manifestations of vitamin B3 deficiency in children. Now, according to the students, there was a condition which was asked in another question, which was Castle's necklace. Now, this is a rash that actually is known to develop usually in the neck area, Castle's necklace. And this is often a manifestation of niacin deficiency in children or niacin deficiency in adults. So in case a question on Castle's necklace was given, or a pictorial manifestation of a rash which was present in the neck area, which mimics a necklace like manifestation over the skin, and they ask the question, I'm not very sure if this question was asked, but if they ask what is this due to deficiency of which vitamin, then it is basically the deficiency of niacin. So that manifestation that is usually present over the neck area is known as the Castle's necklace. Now there is another vitamin which is vitamin B6, pyridoxine. Pyridoxine deficiency is associated with neurological manifestations, particularly seizures. So seizures in newborns. In fact, refractory seizures in newborns may be one of the manifestations of pyridoxine deficiency. Then pyridoxine deficiency may also be associated with microcytic anemias in children. Vitamin B12 deficiency, we all know, is associated with macrocytic anemia. It is associated with neuropathies. So vitamin B12 deficiency is again associated with neurological manifestations, is associated with macrocytic anemias. So anyway, so coming back to our question, angular cheilitis, stomatitis, and glossitis are manifestations of riboflavin deficiency according to me. Now, there was a question which was a swelling seen on the scalp, a pictorial manifestations, and they asked the students to identify this condition. Now, this appears to be either a caput secundum or a Keffel hematoma. Now, what is this more likely to be? You have to see where the swelling is more likely present. See, caput secundums are actually fluid collections between the skin and the periosteum. And usually in cases of prolonged labors, because of the pressure of the vaginal walls on the presenting part of the skull. So there is a swelling that may develop, a superficial swelling, and usually it is known to cross the midline. So you are more likely to see a caput secundum crossing the midline because it is a superficial swelling. And usually most of the times the swelling is seen on the presenting part of the skull. Now here you are not seeing a swelling on the presenting part of the skull. It is more likely a swelling on the parietal part, which is more likely to go in favor of a Keffel hematoma. Kefal hematomas usually are blood collections which are subperiosteal, between the periosteum and the bone. They often are seen after trauma, say for example when you are trying to forcibly extract the head of the child out. So that trauma to the head can lead to the development of a Kefal hematoma, which usually is much slower to appear in comparison to a caput secundum and usually lasts for a much longer time in comparison to a caput secundum. So this does not appear to be a caput secundum. This may be a Kefal hematoma because it is a swelling which is on one side and is not seen to be crossing the midline, crossing the sutures. Kefal hematomas do not cross the sutures because they are subperiosteal swellings. Subgaleal hematomas again are hematomas. So they again are basically blood collection. And they usually are because of the rupture of the emissary veins, the veins which connect the scalp veins to the dural sinuses. But they are much more gross bleeding, and since they usually are above the periosteum, they are likely to be much more diffuse bleeding. Kefal hematomas are more localized kind of a bleeding and usually will therefore be seen as a localized kind of a swelling. Subgaleal hematomas are much more diffuse and they are much more likely to present with deaths very early. Kefal hematomas are not those dangerous. Encephalocele, as I told you, are neural tube defects rather than bleedings. So therefore, according to me, this condition is a Kefal hematoma. Coming to question number 6, which was again a question on milestones, something that I have repeatedly taught in my classes about the time when the child is able to transfer objects from one hand to another hand. This is usually between 5 to 7 months of age. So 6 months should be the correct answer. So this is something that again I teach in my classes. Usually I think I teach this in social milestones. You can also consider this as a part of the fine motor milestones. So when is the child able to transfer objects from one hand to another hand? The child is able to transfer objects from one hand to another hand between 5 to 7 months of age. So approximately 6 months should be the correct answer. Then there was a question on conjunctival cirrhosis. This again is a pretty simple question. Conjunctival cirrhosis is basically a manifestation of which deficiency? So this is very clearly a manifestation of vitamin A deficiency in children. Now, vitamin A is a very important vitamin and its deficiency is associated with conditions such as follicular hyperkeratosis. It is associated with xerophthalmias. It is associated with conjunctival cirrhosis, bite-root spots. Then vitamin A is also a very important vitamin for immune system. So deficiency of vitamin A in children can lead to recurrent GI infections, recurrent pulmonary infections. So that is another manifestation of vitamin A deficiency in children. But I think the classical feature of vitamin A deficiency that you see in children are the follicular hyperkeratosis, which is a manifestation on the skin, and the ocular manifestations of vitamin A deficiency. The treatment of vitamin A deficiency is according to the age group. So less than 6 months, the dose that we normally give is 50,000 units. Between 6 months to 1 year, the dose is 1 lakh units. And above 1 year, the dose of vitamin A is 2 lakh units. This dose is given on 2 consecutive days and a third dose, which is given 14 days after the first dose. So that is how you treat vitamin A deficiency in children. So pretty simple question. Conjunctival cirrhosis is caused because of deficiency of vitamin A. Coming to question number 8, which again was a question on vitamin deficiency. So here they asked a child presents to OPD with fatigue, bone pains and swelling. Now this again is very important. Bone pains, swelling and bleeding gums. So swelling of the gums, bleeding gums, petechial spots, this is all manifestations of scurvy in children. And scurvy is basically vitamin C deficiency in children. Basically, our body is not able to synthesize vitamin C because of the deficiency of the enzyme gulonolactone oxidase. So we require vitamin C from the diet. So basically the green vegetables, the citrus fruits, they are known to provide us vitamin C. Our body is not able to synthesize vitamin C. And vitamin C is very important for collagen synthesis also. So in the deficiency of vitamin C, you have improper collagen synthesis, improper osteoid formation in the bone, which leads to a variety of manifestations, which includes bone manifestations also, and which includes manifestations related to bleeding from the blood vessels also, because obviously the collagen, the tunica media, it becomes leaky. So there is often blood which can leak from these blood vessels. So that leads to the petechiae, that leads to the swelling. Then bone manifestations. So bone manifestations can include pencil thin cortex. Then bone manifestations can also include subperiosteal hemorrhages. Many of these can lead to bone pains also, because whenever the child moves his legs, the child often feels pain in the bone. So that is why the child often keeps his legs in the neutral position, something which we call as pseudo paralysis. Then apart from this, there is a thick white line that can form at the metaphyseal region, the growth plate region, which is called as the white line of Frankel. Then you have a trauma-filled zone, which is basically a radiolucent zone that can be seen below the white line of Frankel. So all of these are the bone manifestations that you see in scurvy. So any child who is presenting with bleeding from the gums, a malnourished child, bleeding from the gums, petechial spots, the child has bone pains, the child has hemarthrosis, that is blood in the joints, the child has typical bony manifestations in the long bones, always think of vitamin C deficiency. Normally mothers are not deficient in vitamin C if they are well nourished. But if the mother is not well nourished, or the mother herself is deficient in vitamin C, then she's likely to pass this vitamin C deficiency to her baby also, because the breast milk will not contain adequate amount of vitamin C. So in such cases, vitamin C deficiency can develop in children. And then the children can start having manifestations of these conditions. So the treatment is by giving vitamin C in the as supplements to these children. So I hope you have understood about vitamin C deficiency and the manifestations of vitamin C deficiency in children. Now this is basically question 9, which was basically a question about a teenager female brought to the OPD with history of delayed puberty, and the child was having short statures, widely spaced nipples. I think this again is a pretty simple question. You must have understood this condition. So this is a condition which is called as the Turner syndrome. Turner syndrome basically is one of the most common sex chromosome related abnormality which is seen in a genetic disorder, which is seen in females. It is a condition which is very commonly associated with cardiovascular manifestations. So we often teach about Turner syndrome in cardiovascular disorders also, because of the manifestations of congenital heart diseases, which can often be co-associated with Turner syndrome. Now, Turner syndrome commonly occurs because of either deletion of one X chromosome or basically non-functioning one X chromosome. So typically majority of, I will not say majority, but many of children with Turner syndrome have XO karyotype. But unlike what we might believe, that XO karyotype is typically seen in all females with Turner syndrome. So Turner syndrome is seen only in females. So unlike what we might believe that XO karyotype is seen in all females with Turner syndrome, it is not the case, because there are many females with Turner syndrome who have a mosaic karyotype or a mixed karyotype. So when we say mixed karyotype, that means some of the cells in these children have XO karyotype, while other cells have other type of karyotypes. For example, they might have 46XX or 47XXX type of karyotypes. So we have mixed type of karyotypes, XO in some and 46XX or 47XXX in some. In other cases, say about 45 to 50% cases, it is pure XO karyotype that can be seen in majority of children with Turner syndrome. So this is basically a case of Turner syndrome. What can be the manifestations of Turner syndrome? Well, the manifestation of Turner syndrome can include short statures, a short neck, webbed neck, widely spaced nipples, cubitus valgus. Cardiovascular abnormalities are one feature of Turner syndrome, which I often teach in my classes, especially bicuspid aortic valve and coarctation of aorta. These are two important cardiovascular manifestations that you can see in Turner syndrome. Turner syndrome then can also present with short metacarpals, short metatarsals. It can also be associated with congenital lymphedema of the hands and feet. So it is one of the Down syndrome, Turner syndrome. These are some of the important genetic disorders that you see in children. Turner syndrome, especially in females, is a very important disorder. And please also remember that unlike what many people conventionally believe that it is inherited, most cases of Turner syndrome, as far as I know, are not inherited. So they are not actually, despite being a genetic disorder, it is not an inherited disorder. And that should tell you one thing, that all disorders that are genetic disorders are not necessarily inherited disorders. Then there was another question about a child with diarrhea who was eager to drink and skin pinch went back slowly. So a child who is having diarrheas, having dehydration, and the child is eager to drink. So the child appears to be thirsty and the child's skin pinch goes back slowly. So this shows that the child most likely is in some dehydration. Now the question that he's asking is that the child should be classified in which of the categories according to the IMNCI classification, that is Integrated Management of Neonatal and Childhood Illnesses. See, IMCI was Integrated Management of Childhood Illnesses, was the WHO based program which basically mainly aim to identify children with the major symptoms of or major signs of illnesses that are commonly known to cause mortality below 5 years of age. So basically it was a program that was aimed to identify the danger signs and major symptoms of diseases such as diarrheas, cough, breathing difficulties, fever, ear pain. So basically the idea was to identify the major diseases or major symptoms of diseases which are known to cause deaths under 5 years of age. So this program only aimed at evaluating children below 5 years of age. India adopted this program and included neonatal evaluation, neonatal children also under this program. So this program came to be known as IMNCI, Integrated Management of Neonatal and Childhood Illnesses. Now basically the program works like this. So initial part of this program is assessment of the child. So whenever a child is brought to you in the health center, you have to assess the child for the presence of any danger signs or the presence of any major symptoms, as I told you, of diseases which are likely to cause deaths below 5 years of age, like pneumonias, like diarrheas and dehydration. So you have to identify major symptoms of diseases below 5 years which can cause diseases and also which can cause death, and also to identify any danger signs. The danger signs like unable to drink, persistent vomitings, child who is convulsing or has history of convulsions, child who is lethargic. These are the danger signs which should put a child in a sickness category, a sick category. So assessment of the child is the first part of this program. Now the next part of this program is, according to the assessment, the doctor will classify the child. Now classification, the doctor will classify the child into one of the three categories which have been given different color codes. So there is a red category, which, or a pink category or a red category, which has been given a color code, red or pink, meaning this is a child who is a very sick child and requires an urgent referral to a higher center. There is a second color code, which is a yellow color code. This category includes children who need treatment in the OPD basis and require definitive follow-ups. However, these are the children who do not require, who are not sick enough. Majority of them are not sick enough to be referred to a higher center unless and until there are other co-associated sick categories associated with these children. So a child coming to you with the diarrhea, a child coming to you with the diarrhea and dehydration, who otherwise is in severe dehydration, will be put in a red category, because this child is a child who requires an immediate treatment, and in case that IV treatment is not available, immediate referral to a higher center. But in case the child comes to you in some dehydration, now this is a child who does require ORS, does require treatment, but is not sick enough to be immediately transferred to a higher center unless and until there is another severe category associated. For example, this child has a severe pneumonia co-associated with some dehydration. Then this child requires an immediate referral. But if the child has only some dehydration, so this child does require treatment in the OPD by starting ORS according to the some dehydration plan, but does not require immediate referral to a higher center. So some dehydration child will be put, according to me, in the yellow category and according to the IMNCI classification also. Now third is the group of children who have been classified into the green category. Now the green category is a category which basically is simply home management. You might be following up the child for further evaluation, but right now the child does not require specially any antibiotics. So this category is basically the green category. So a no dehydration child who right now is not in any dehydration may be put in a green category. A child coming with cough and cold having no pneumonia will be put in the green category. So the first part of IMNCI program is assessment. The second part of IMNCI is classification into one of the severity categories according to your assessment. And third part is now starting the management according to the risk group to which the child is assigned. So you are assessing, then you are classifying the child into one of the risk categories according to the color coding, and then you are starting the management in the child according to the risk category to which the child is assigned. So this is a very short and a very brief way of telling you about the IMNCI. So what are the color categories? The pink color means, or the red color means, a immediate referral to a higher center after giving, say, IV antibiotics. So one shot of IV antibiotic, immediate referral to a higher center. This is a very sick child. A yellow category means a child who is requiring management, say antibiotics, but can be managed usually in the OPD with definitive follow-ups at regular intervals. So every 2 to 3 days you need to follow up the child to see whether the child is not deteriorating. And in case the child is deteriorating, then obviously again refer the child to a higher center. And green category is the category where the child right now does not require usually antibiotics and can be managed at home. For example, a cough and cold, so you can manage the child's cough by home remedies. And yes, the child in between may require follow-ups to see that the child is not deteriorating. So this is the part of the classification which is known as the IMNCI classification and the management plan according to the IMNCI classification system. Then there was a question on a neonate presenting with respiratory distress. Some students say that there was an X-ray that was given in which there was X-ray showing bubble walls that were present in the thorax. Anyway, this question again is pretty simple. If you are seeing air bubbles in the hemithorax, or if you are seeing the bubble walls in the thorax, it is very clearly a case of a congenital diaphragmatic hernia. We still are not very sure about what other options were, but this is very clearly a case of a diaphragmatic hernia. Diaphragmatic hernia is a condition in which there is basically herniation of the abdominal contents through a defect in the diaphragm into the chest cavity. So this problem starts usually from the fetal period. So the lungs do not get the space to grow in the thorax, and this can often lead to the development of pulmonary hyperplasia. And pulmonary hyperplasia is one of the common causes of deaths also in these children. So either the herniation can be through foramen of Bogdalek, which is usually present on the left side, or through the foramen of Morgagni, that is present on the right side. So presence of bowel, presence of air bubbles, presence of stomach on an X-ray in the chest cavity usually will be indicative of a child having a diaphragmatic hernia. So these all are the questions that I could get from the students. And the options also, we have, as I said, the aim has been to keep the questions and the options as near to the actual questions as possible. However, please do pardon us in case the questions or the options have not been exactly the ones that have been asked in the exams. My answers to these questions were strictly based upon the options that I could get from the students. In case the options were different, then probably yes, the answer would be different. I would be always available at DBMCI to help you out from for any pediatric query. So please feel free to contact us on the Facebook and the Telegram group for any of your doubts regarding. For me, you can ask any of your doubt regarding pediatrics, particularly per se. So thank you very much for attending this session, and goodbye.